So just while we're waiting to get going, I'll remind everybody to try to make sure your mute is off. We do hear a couple of voices. On one of the screens, what will happen if your mic is on, you might show up. Although, Doug Garland, we have you full big screen, and you seem to be mic'd off, but somebody with the noise in the background, so just make sure that everybody's muted off so there's not too much feedback. I can't see everybody that's linked in. I'm expecting that we have some sites also. I've got all the individual call-ins through the WebEx, and then I'm expecting that there'll be the clinical sites as well. So we'll get started. Welcome to Clinical Rounds for January, first presentation of 2020. I'm Dr. Floyd Besserer. I work as an LMC in Prince George, and I'm also a part-time critical care paramedic at a 580 station. I was asked to give a talk, and I thought that handovers and communication is something that we're trying to work on locally in our department. I thought that it may be relevant to the masses here, so we'll have a discussion today. The picture you see is a handoff from football, and I am still grieving the Packers' loss last weekend. In light of football, I thought the Super Bowl coming up next weekend, I thought we'd have a football-based theme. I won't share who my team that I'm going to be cheering for next weekend is in case I upset some people. So again, we're coming from Prince George, the Great White North. Dr. Spooner and I had talked about maybe doing a presentation a la Bob and Doug McKenzie, but thought that in the context of professional handover, toques, plaid, and beer drinking probably weren't the theme that we wanted to share. Up here, as with what sounds like much of the province, the weather's been a bit extreme over the last few weeks. We've gone from 3 feet of snow to minus 44 to now plus 5, and so modes of transport in the side streets in Prince George anyway has moved from essentially snowmobiles to canoes. I hope that that's not also the case elsewhere. So from a disclosure standpoint, again, I'm an LMC, so I am paid through BCEHS. At CCP as well, I'm paid through BCEHS. I have no other financial disclosures or conflicts with any of the stuff that we'll be talking about today. Just picking up a bit of feedback there, awesome. So the big thing today that I want to talk about is just overview of the role and the importance of clinical handover. I think we all somewhat understand that, but we're just going to highlight some of the key concepts related to that. And also, when we do that, talk about a bit about performance under pressure as they relate to communication. And then we'll look at a new up-and-coming clinical practice guideline through BCEHS on clinical handover and communication. So while I was looking for some statistics, BCEHS-based statistics, I stumbled across, this journal comes out every month, but this is a new publication in January 2020 edition of the Canadian Journal of Emergency Medicine. And so I just wanted to extend congratulations to the authors for putting this out. Essentially, as you can see, it looks at resource allocation plan that's been implemented within the organization over the last 9 or 10 years. So an interesting read. I encourage you all to have a look at it. It should be open access to be able to link that. If not, you can get a hold of me, and I'm happy to share that. So from that paper, interestingly, it shows that dispatch call volumes every year, more than 500,000 calls. In each one of those, we're going to touch a lot of patients. So every single transported patient that we are involved in gets handed over in some way, shape, or form, either at the hospital or within crews much of the time. So there's an enormous amount of communication related to this job, as you guys know, and there's many layers related to that. And so just think about the amount of times, either on a shift or in a year, that you're giving handover or receiving handover as well. It's not a one-way street. And teams have to recognize that. So it's not just us as the bedside giving report to the nurse, giving report to the trauma team in critical patients, in stable patients, etc. It's also pulling that information and understanding what information is coming and in what format that's coming that helps to optimize how that information is transferred. This is actually a picture of, I believe this is Granville. So going screen left, screen right is Granville, and away is a cross street. I hope it still doesn't look like that down there. Yeah, this was a pretty interesting pic. So when it comes to handover, we've all seen it. There can be a dichotomy. The degree of control or chaos can be extremely variable. You can either have, on the left, the calm, orchestrated symphony, or you can have the chaotic, loud, chaotic mess. Each one of us is individualized and probably functions to a certain extent better in one of those extremes or somewhere maybe in the middle. Think of a few times in handover situations where you've seen either one and which one makes you comfortable or uncomfortable, or where you think that information was lost. So I just want to set the tone and just picture a case. You're on shift and you're called out to a single vehicle high-speed MVC, car versus pole. There's an unconscious single occupant with obvious head, chest, pelvic, and long bone injuries. Fortunately, you've expertly extricated, intubated, sedated, needle decompressed, started 2 large bore IVs, bound the pelvis, splinted the long bones, and pre-notified the accepting hospital very smoothly and very expertly. Your patient is very well packaged and is now hemodynamically stable. So you walk into the receiving facility, wherever it is that you work or you go to, with a little bit of swagger. And the trauma team that you see is what awaits you. They ask you to give handover to the room. But you remember that the last time you did this, it was a terrible experience. And so as you go to give report, your mind goes completely blank. You end up giving a disjointed, incomplete report. And when you walk out of the room, you feel a bit like this guy. Once you've recovered, you're faced with a similar situation. In a sick patient, you've managed them expertly, you've packaged them well. And again, you're coming into the same receiving hospital and they ask you to give a report. This time though, rather than walking in like this, you walk in like this. So how can we improve that sense of fear or whatever it is when you walk into a busy trauma room and have to give report? It's like giving a speech to everyone in a relatively highly intense situation. That's what we're going to talk about today. We're going to talk about some strategies to turn high acuity handovers into a calm, controlled, thorough handover that leaves you feeling confident and optimizes patient care, as opposed to feeling like this guy. So I want to talk a little bit about the psychology of performing under pressure. Everybody here works under pressure every single day. So I'm not going to teach you anything about how you should do it better. or things you should look at. We're simply going to look at some of the theory behind performance and pressures, and specifically as it relates to clinical handover. And all of this is influenced by experience, it's influenced by training, it's influenced by protocols. This book, if you haven't seen it, is a relatively new book, just out in the last 6 months to a year, written by HEMS UK, named Dr. Stephen Hearns. It's an excellent resource, and I highly recommend looking at it. It's an easy read, and it breaks down multiple concepts related to the psychology of performance under pressure. I don't have any financial interest in this book, but it's available on Amazon. You can get Kindle format, etc., etc. Very accessible. So I'm gonna refer to a lot of the concepts, and some of the images that you're going to see are specifically from this book with regards to performance under pressure. So this is an age-old performance curve. We've all seen this. If you've taken Psychology 101 at any point or read anything about this, you've seen this flow curve, this curve, where you've got performance on y-axis, pressure on the x-axis. This comes back from way back in 1908, and it still fits today. And so Dr. Hearns is breaking down performance essentially into these three different levels. You're either disengaged, depending on the pressure, you're optimized, so your flow, and he refers to it as flow. That's where you're like, you can think about a time when you've either played sports or done a presentation or been on a busy call, a sick call, where you feel like you're in the zone. That's flow. And then when you get beyond that, you get frazzle. I wasn't too sure about frazzle. It kind of sounds like Fraggle, so I just kept thinking back to Fraggle Rock, but it's where you get completely out of it, and your performance is affected negatively by it. And so he uses a closed pressure system to think about flow, that peak area part of the curve, flow, how to control that flow and be in that flow area when you're in high pressure situations. There's different components, as you can see, to the flow system that he talks about. Four main ones: the pump, the control, testing, and relief. The pressure pump, he defines it's all about organizational support. So the pump is where the organization that you work with, or the group that you work with, or the team that you work with provides support, provides tools, provides training, provides everything else to optimize your performance. The control is various tools and aids that you can use to turn the valve to optimize how much pressure is in the system. This is where he talks about checklists, cognitive aids, guidelines, process guides. Pressure testing is training and simulation. So by using it over and over, things over and over and over again, it becomes part of our being, and we improve our performance under pressure. And that comes down a little bit to the psychology that we'll talk about in a little bit. And then there's the pressure relief. How do we debrief? How do we cope downstream of where that pressure is influenced on the system, so that the next time we know we can control the flow better? So it's a really interesting concept that he's put out. So again, external pressures on the system negatively influence the degree of flow and how you perform. This could be anything from time pressures, the degree of acuity, the level of emotion, past experiences. All of those can have a negative impact on your performance. Today, what we're going to talk about are things related to pressure control. We're going to talk about clinical handover and the use of tools to try to optimize handover in a highly stressful situation. Not just that. I mean, people are going to ask about, well, what about when we're not walking into the trauma bay and we're just going to triage and we're going to report to the triage nurse or to the bedside? This will cross over. It's a little bit less pressure. Today we're going to focus on more of the high acuity stuff, but a lot of this just all transfers. Okay, so we're going to talk about pressure control, and then we're going to talk about the pump, development and implementation of tools and training to help guide us through that. So pressure control. I think it's it's important for us to understand how we think under pressure a little bit more. So thinking about the psychology. Dr. Hearns goes into a little bit about memory pathways and how they're influenced. So you can split memory. This is a busy slide, and I apologize for that, but you can kind of split your memory into two pathways, explicit and implicit. So explicit is the stuff where we can remember words, textbooks, that type of thing, episodes. It's that stuff that we can pull from our memory banks and think about. It's difficult to use that in high stress situations. Implicit is more of our conditioned and automatic learning, where we use previous experiences to learn things. And that same thing with procedures and skills. So riding a bike, yeah? And then the conditioned automated learning is experiences you've been in that have either negative or positively influenced you that would lead you to act in one way or another. So yes, sticking your hand on a hot stove, you've learned that that's not a good idea, so you reflexively pull back. Or you've had a negative emotional response, much like that guy who got punched in the face after giving a disjointed handover, learned from that response and now has to try to alter that automatic reflex of panicking when he or her goes into that situation. This is another great book. I don't know if anybody's read it, Thinking Fast, Thinking Slow. I've read it. Dr. Hearns actually refers to it in his text. And it's all about ways that we think and how we deal with situations. The high-level overview of this is that we use fast automatic processing, and we can also use slow analytical processing. This fits also clinically. You can think about type 1 fast processors. So someone who's been on the job for 30 years walks into a situation and automatically uses past experience to make rapid, successive decisions based on that experience. Someone who's been on the job for 6 months walks into the same situation, do not have the experience to draw on, have to think analytically, have to take data points, put them together, and think through them. Now, because the person with 25 years experience relies on that automatic, quick processing, doesn't mean that they're always right. It's much more likely, more prone to error when you're relying on previous experience and trying to relate them to the current experience. And so fast automatic processing, we don't use much cognitive capacity. It's nice. Think about it when you walk into something like a quick situation and you just automatically make a decision. You haven't had to think about it. It doesn't tax your cognitive capacity. So it's ideal for low-risk tasks. But again, it is prone to error. Slower analytical processing, you need to be able to gather info, explore options, and make conscious decision. This is where we use the explicit memory that we talked about before, things that we've memorized, lists, terms, taught in the textbook. But you need much more cognitive load, and it's a much slower process. I would argue that in a lot of high acuity situations, yes, fast is good, but to get to fast, we need to go through a bit of a slower process. Somebody, I don't know where I heard this before. I think it was one of my mentors when I was in residency, and I think it came out in a simulation at one point where as a team we just kind of rushed through and totally missed a differential on our diagnosis and the patient crumped, et cetera, et cetera. And he told us, you guys were fast, that's great. You jumped into action and did things rapidly. But remember that slow is smooth and smooth is fast. You can get very inefficient if you get down a rabbit hole through rapid automatic processing and you've made an error, then you've got to backtrack. So by taking the information, putting it together, and acting efficiently on it, that's just as fast and it's better outcomes. So slow is smooth and smooth is fast. So in handover situations, process guides allow step-by-step instructions through which unfamiliar and high-stake procedures are facilitated. And so the important part here when you go through process guides is, yes, it helps to slow things down, think strategically through each one of the points, but it allows for that transition between parties. The receiving party has to be on board and understand the process that you're going through with the guide. You can't just take a guide in. You can, I mean, if you walked into a room of somebody that's never heard of a mnemonic or an acronym, and you go through things, it's somewhat structured in your mind, and it gets the information across. But unless the receiving party really understands where that's coming from, they may think that it's disjointed or there's things missing, that type of thing. So you need to have both parties on board with that. But these things, these process guides allow us to compartmentalize and slow things down. Okay, we're going to just switch away a bit from the psychology and talk a little bit about the pressure pump. So how can an organization help control the flow or the stress that's there? And that essentially is what we're going to get to the latter half of this talk, is implementing clinical practice guidelines, giving you tools to use in order to facilitate the communication. Now, not only, so if we're talking strategically about handover process just within, say, our own organization, BCEHS, it can't just be that. That's not the only component of the pressure pump. But again, the receiving components, so the health authorities and the hospitals, everyone has to be linked on this in order to get good buy-in and facilitate the process that we're going to move through. Right? So we want to create, between all organizations, we want to create a culture of excellence. And in handover, excellence is getting correct information in a smooth, controlled manner across that minimizes error and enhances user satisfaction. Now, it's a vast and complex initiative trying to implement a clinical practice guideline or a process tool to an organization that's as big as ours. If we're a team of 4, it's pretty easy, and we've got 4 people to train, everybody's on board, everybody has input. It's difficult when we have thousands of people literally having to do the process. So before we jump into an initiative like that, you want to make sure that there's proof in the pudding, that there's evidence to support what you're trying to implement. And so we'll talk a little bit about evidence with regards to process guides and handover tools and stuff. So the Canadian Medical Protective Association is essentially a national organization that provides medical legal protection for physicians. Their mandate, though, isn't only to provide medical legal, but it's also to provide us with education and resources to empower better healthcare. That's their goal, and they do a fantastic job of that. So their website, it's free to go to. You can go to their website, and they've got tons of resources on there, not just on this, but on a multitude of topics. They outline 4 strategies to improve handover communication using one of their good practices guide. And so the first component of the first strategy is, in the process components, to address the physical environment. So think about, again, we go back to the case that we talked about before, or cases that you've been involved in on your own. Think about walking into a trauma bay or a resus bay, or essentially maybe a monitored bed at some point in time with a relatively sick or critical patient, and think about how the room was set up. Where were people standing? When you gave handover, where were you standing within the room? Was the bed together? Could you get the stretcher in? Were you tucked in behind the stretcher? Do you think that the person who was recording the information could receive the information? Could they hear you? Could the whole room hear you? Was there anything lost? That's an important component because, one, it you ensure that you physically can hear things, but it also lets you cognitively pick up. If it's the room, and obviously you're not going to be able to standardize every room because all facilities are different. But generally speaking, by having a controlled environment, it's going to be much easier to transfer that information. Adjust time constraints. I'm an emerge doc. I have a very short attention span, generally speaking. Handover needs to be, yes, thorough, but it needs to be quick, because I will start losing my attention after a period of 60 to 90 seconds. I think I've got the key information. I have to force myself to lock my feet to the floor and keep listening. That's part of the training, and that's part of the pressure pump, right? The organizations need to support that, and that the teams receiving handover also have to work on that. Effective listening skills can be just as important as effective giving skills, so to speak. So we have to make sure that the timeline is set as to what the standard information that needs to come across is in what time. Communication skills. So this could be as simple as, how articulate are you? How clear are you? What volume do you use? Now, volume can be, louder isn't always better. Louder can make people turn their listening off quite quickly if you're being yelled at right in the ear and you want to move over. But all of those things are things that we can improve, and that comes with practice. Unfortunately, it comes with listening to yourself talk sometimes, or recordings and things like that. Or if I listen to myself talk on this recording, I'm going to probably shake my head tomorrow if I listen to it. Why did I say that? But that's part of learning and a part of the process. They also talk in this about flattening hierarchies, though. So when you're giving a report, it's a report to the team. How many times have you walked into the room and you've triggered somebody who's wearing blue scrubs, and you're like, that's the physician, and you walk over and you start talking to them, and then they go, I'm a second-year shadow medical student, and you've given half your report already because they stand there with authority, wearing the right clothing. So we need to try as a group to flatten those hierarchies. It's a team approach when it comes to handover. And then standardized communications. So they talk about using tools or structures to facilitate standardized communication. There's a multitude of tools out there. SBAR, everybody's familiar with that. That's a way. Every tool has pros and cons. There's no wrong or right answer for the most part. However, some are more appropriate for certain contexts than others. So the evidence, so this is just a few of the studies that I've pulled, read through, and had a look at. We're not going to do a comprehensive literature review of everything. Clinical practice guideline that we're going to talk through in 5 minutes here has gone through and looked at the evidence, and they've reported that on that guideline. It's quite good. There's tons of evidence out there right now. Unfortunately, most of them in their conclusions all say more research is required in this area because we don't know the best option. And sometimes it's not. It's specific to one context versus another, like we talked about. 2009, Dr. Alex Carter, who's an emergency physician note in Dalhousie and the medical director for EMS out there, so she did a study looking at how much information that's handed over from crews is actually documented on the paper chart. Roughly, what do you think? What percent?
20.
20.
No, I think like 60 or 70.
Okay.
45.
Okay, so I've got a breadth of numbers here, anywhere from 20 to 70. We have pessimists and optimists. 70%, about 72.9%, I think, is what the final number was of information they found was actually documented and transferred in handover. There was another study done in the U.S. on trauma in the context of trauma handovers, and they found very similar numbers. 75% of the information that was brought forth was documented, which isn't bad, but 25% leaves a very large window for maybe a critical piece of information that the team could use. The at-MIST, so you saw in the last slide there we talked about at-MIST, and it's a tool that MIST essentially it was developed by the military, and there's not a lot of information or literature out there describing where or who developed this. It seems to be maybe from the Afghan conflicts, but I'm not sure how far back it actually goes. I couldn't really track it down that well. But the MIST component came from there, and then the at component, age and time of incident, were kind of added on afterwards that I can see. It sounds like, it's been well proven, it's been accepted by a number of organizations, but I think most of the data is lying in QI level data. So organizations and hospitals are looking at this handover format, they're assessing it from a quality improvement standpoint, but then the data isn't published. So it's proven within the organization, but it never gets published or disseminated. That's what I think is happening, but I can't be positive. There is an article that I'm hoping to read that I haven't seen yet in the Journal of Paramedic Practice that's just out recently, I think this month, looking at military versus civilian handover and MIST as a component of that. And I think it'll be a good paper just from the sounds of the title, but it's difficult because it's not actually available through the library system yet, so I have to do some digging in order to get it. This paper is very well written, very succinct, and it's a summary on clinical handover. It's coming out of the UK. It discusses barriers, formats, and practical applications of handover. And there's different formats of tools, but they refer quite a bit to the at-MIST format. They summarize in their summary table at the end of the paper. They just look at practical recommendations to improve quality. So prior to handover, using a written template, which is essentially what we're talking about. Try to minimize that cognitive load. Practice your handover prior to hospital arrival. I don't think you need a mirror and hold that up or record yourself, and you don't have time to do that stuff. But try to get it run through it in your head. And the use of a card or a tool in your hand physically to do that helps to improve your ability to deliver that verbally. And then they recommend transfer the patient to the hospital trolley, well, I don't call it trolley, stretcher in Canada, prior to handover to minimize distraction. So that becomes a process piece that you have to have collaboration with your receiving facility. Some places will want the patient to stay on the cot and then get handover and then move over. Some will want to move over and then get handover. So that's a give and take, and that's something that with your local facilities we work towards to try to improve the physical environment and the process that happens. And then delivery. You can read through all this. I'm not going to read through everything for you, but it's quite a good summary. And so I would have a read through that. This is a very extensive thesis paper on handover, communication in military, and the NHS, which is in the UK, in emergency care settings. It's a mixed qualitative paper, so they don't measure quantitative data, so things that have handled order bios, that type. They measure what people's experiences are with it, and then they use different domains or frameworks to analyze people's comments, literally verbatim, like interviews, and they try to pull themes out as to what the common themes are. And so she did a fantastic job on this, and I don't see it published anywhere specifically in a journal, but it's accessible online. And the summary of their key findings, this, I don't know how many pages this is, probably 100-page document, is that there is not that much known. Although a lot of papers are out there, we don't truly have the granular data to prove anything. But between the civilian and the military components, there are some differences. Military definitely standardized they focus on standardization using the ATMIS format, as opposed to something with more of a subjective component to it, such as SBAR or IPASS, or one of the other ones that are commonly used in the hospital with regards to transfer floor to floor. And then, yeah, you can read through, again, through the rest of them. But the transition theory is an important thing that they recommended. With all that being said, they say that the paramedics that were in this study, they had a difficult time going from military back to the civilian handover type formats. And so obviously the NHS has looked at some of the data that's out there, and then now they've accepted and implemented ATMIS as their handover format, specifically for higher acuity patients that you're going to be handing over in the trauma bay or in an acute type setting. But personally, I think that it crosses over well into even the lower acuity patients. I just don't think it's been studied in that format because it does come from the military and trauma-based settings. The Resuscitation Council of the UK also endorses the use of ATMIS in their processes. So what I'd like to do now, I'm not sure, I wasn't sure if this was going to work. Leon Baranowski is, as many of you know, is one of our paramedic practice leaders. He's been working with Shauna, I see your name on the board, he's working with Shauna Spears, who's an advanced care paramedic on the Lower Mainland, and they've done a great job of drafting a new clinical practice guideline regarding clinical handover and communication tools within BCEHS. So Leon, I'm not sure if you're able to unmute your mic. I was hoping that Leon, because they've done such great work on this, I wanted to give them the credit and let them discuss a little bit about the clinical practice guidelines. So Leon, if you're there, or Shauna, if you're there, if either one of you want to unmute, I'll hand the floor over to you to have a chat about this.
Morning, Floyd. Can you hear me?
Yeah, we can hear you great. Thanks, Leon.
Awesome. Thanks for having us on this morning. I think Shauna's on as well. Shauna, I'm not sure if you want to join in. This was predominantly led by Shauna. Just supported through some peer review and edits on this, but a majority of this is her work. And you know, kind of off the back of what Floyd's pulled together as the reasons why in a lot of the literature this morning. So I don't have any slide control, Floyd. I didn't know if there's another slide beyond this, or if you just kind of want us to give a high-level overview of what we've been doing.
Yeah, if you want to give a high-level overview, Leon, that's great. I do have my next slide essentially is the tool itself. Yeah.
Awesome. Yeah. So kind of as Floyd has given you an overview there as to the importance of communication and why it matters in handover. We've been working with one of the accreditation teams, which is got lots of different leaders in from both operations, dispatch, and learning and quality to look at a way in which we could improve the way that we do this, but also work with our external healthcare partners in the hospitals. And Floyd and Dr. Devin Spooner up in our northern region have been championing and leading the way with kind of an interdepartmental initiative. And what was born out of that was the development for, or the need to develop our own or a revised version of our own CPG to fit into the new CPG projects that provides what the BCEHS standard will be for clinical handover and a structured approach. So what Lloyd has laid up there on the screen for you in terms of the model that we've gone for is kind of a little bit of a blend from ATMIS, which is what Floyd was just talking about, traditionally was used in the military. I used it in my own practice on HEMS back in the UK. And then we've looked at other areas around the world, and one tool that's used in Australia is IMIST AMBO. So they don't have the ATMIS piece, but they have the AMBO piece. So when we actually kind of looked into it at the end, we still feel that that information is very pertinent to a clinical handover. So allergies, medications, backgrounds, that might be social history or anything else that you kind of need to add in about the family, and then any other information that may be pertinent at that time to the patient's care that could be not otherwise placed in the above structure. So we've taken this through some clinical governance in BCEHS with lots of different stakeholders. We've tweaked it and redesigned it, and this is the tool that we've effectively landed on and we'll be looking to implement as part of the new CPG project later on this year. Floyd, do you want to speak to the kind of trial sites that we're going to be doing?
Sure. So there's going to be a number of trial sites across the province. I'll speak more specifically to our site in Prince George. And so not only are we going to be looking at using this from a BCEHS standpoint, but we've already discussed this with Northern Health and with UHNBC, so that we have all players on board. We talked about this, it has to be a team approach and creating a culture of excellence. So we've spoken with nursing leaders and physician leaders here, and we've gained approval to try to create a teaching tool for our teams within the emergency department for receiving handover and a structure. So between the two organizations, we're going to try to create a format for which our handover in high acuity patients, we're going to use those patients to start with, and then we'll branch out from there. But we're patients STEMI, hot stroke, time sensitive, patients trauma, anyone that's coming in that's going to need pre-notification and come into an acute bed, we're going to work on this process. And we're going to work on the physical environment that we discussed earlier, how the room is set up and how people are laid out and who's communicating what. And we're going to try to flatten the hierarchies and have a team-based approach to every handover. And the UHNBC is, and I think it's also happening at VGH, the charge nurses, they've all created a document essentially that uses the ATMIS format for pre-notification. And so we'll have a pre-notification process that will use the ATMIS format where when you call in with a sick patient coming in, you'll give that quick handover over the phone, roughly with whatever information that you have from it, so that we're expecting that, and that's documented formally on a piece of paper. And then the teams will be educated. There will be a document with ATMIS, AMBO at the bedside, as well as a poster board up so that everybody can ask questions if there's a component of the handover that's been missing. I will be watching my watch to make sure that you don't take longer than 90 seconds. So but we're going to work together to try to figure out what the best format and structure is for that. We're going to implement it here, trial it, and tweak it a little bit and try to facilitate it, and then give that to other facilities to see how they can work it into their systems with regards to receiving care.
Yeah, and I think Floyd, that's essentially the main thing here. This isn't BCEHS going at it alone. For this to truly work, as Floyd's articulated across this presentation and outlined within the NHS, this is truly a system change that will take some time to implement across the province. It's going to require the whole province and PHSA and all the other health authorities to kind of really start to embed this in their practice. So whilst it's an initiative and a change that we're looking to lead internally, it's also one that we're looking to kind of help support externally. And again, just kudos to Shauna Spears. I was just counting up the references. She's done a very comprehensive literature search and review. There's over 20 different articles and journals that she's found and looked to kind of back up the importance of communication when we're looking at the need for CPGs like this one. It may change, it may not change, but as Floyd says, the intent is to use this as a pre-notification tool. So when you're ringing up to do a pre-alert, and then when you get to bedside and you are welcomed into the trauma room, then you'll be able to kind of rattle off the entire handover, structured, clear, and welcomed.
Yeah, thanks, Leon. I think that one of the questions that's come up is, when we're calling in pre-notification, time limited, resource limited. So we haven't formalized any of this yet, but the thought will be that the ATMIS component will be the pre-notification piece. You may add to that by the time you get to the hospital. You know, when you're practicing in the mirror on the way in, your handover, you may add to that. But then at the bedside, important things that always get handed over, both in the trauma bay and at triage, are the AMBO components: allergies, medication, past medical history, and other information, families coming in, families on the way, that type of thing. That can be bedside. That's not something that you have to on the phone go through all of that stuff, as long as we have the high level stuff in pre-notification. And that's part of the process that we're working through, is how to iron that out. Thanks, Leon. Thanks so much. That was great.
No problem. Thanks.
So again, it's a collaborative process, and I think we shouldn't focus just on the what, just on the tool, on the at-NIST AMBO tool, but we need to focus on the how. So how does it work? Because that is what shifts us from chaos to calm, right? That rave scenario to the orchestra. That's what we want to make sure that we smooth out, and that's going to be a collaborative effort in order to do that. So just in closing, in review, highlights benefits of effective handover. It improves patient safety, it enhances user satisfaction, and enhances system flow. That's well documented in the literature. Those are easy things. Control your flow. When you're thinking under pressure, making high stakes decisions, slow is smooth, smooth is fast. Use tools, much like the one that we've talked about here, to control the pressure and cognitively offload in those high pressure handover situations. And then work together on the pressure pump. Create a culture of excellence. And remember that how is just as important as what. So we need buy-in from all parties. So be a visionary and try to get people to buy in, if you're, depending on whatever site you're working at. Talk about it, get it out there so that we can standardize this. Okay, thanks very much, everyone. I'll open the floor to discussion, questions either to myself or to Leon or to anyone else. But thanks for your time. Thanks for coming out today.
Just a reminder, everybody, Maria's just posted in the chat room, if you can all see it. Obviously now with the need to get your CME credits and the way in which EMALB are requiring your attendance, if you can click on the Google link that Maria's just posted, then this will collect information that we'll send off, and you should gain a certificate and EMA credit for today.
Perfect. Thanks for the reminder. Okay, thanks everybody.